Hi everyone, and welcome to our module on heart murmurs. Heart murmurs are sounds that can be heard with the stethoscope. They are caused by turbulent blood flow as blood moves through the cardiac chambers and the valves of the heart. Many heart murmurs are normal, but some can be pathologic, and we'll talk about all of these in this video now. Let's first talk about how we grade murmurs. When we listen to a murmur with the stethoscope, we give it a grade for the intensity of the murmur, and we give it a grade on a scale that goes from 1 to 6. A grade 1 murmur is barely audible on listening carefully, a grade 2 murmur is faint but easily audible, and a grade 3 murmur is loud and easily audible and has no thrill. And most of the murmurs you will hear in actual clinical practice are grades 1 through 3. Grades 4, 5, and 6 are rarely heard in actual practice and rarely used when describing murmurs in actual practice. A grade 4 murmur is loud and it also has a thrill. A thrill is a vibration you can feel with your hand placed on the chest. A grade 5 murmur is heard with the scope barely touching the chest, and then finally, a grade 6 murmur is audible with the scope not touching the chest at all. For your board exams, this slide contains the most important information for you to know about murmurs. This slide shows the listening areas on the chest where different murmurs can be heard loudest. And in a board question, they're going to say the murmur is heard loudest at a certain location, and if you know the things on this slide, you'll be able to identify which murmur they are describing. Let's start with the aortic listening area here. This occurs at the right upper sternal border at the second intercostal space. This is where you can hear the murmur of aortic stenosis, also the murmur of aortic sclerosis, both very, very common murmurs in clinical practice. At the left upper sternal border and the second intercostal space, this is called the pulmonic listening area, and this is where you can hear the murmur of pulmonic stenosis and also where you can hear the murmur of a patent ductus arteriosus. The left sternal border at the third space is an area called Erb's Point. This is where you can hear a couple of diastolic murmurs. You can hear aortic regurgitation and pulmonic regurgitation, both of which are diastolic murmurs. This is also the area on the chest where you can hear the murmur of hypertrophic cardiomyopathy. At the fifth intercostal space at the left lower sternal border, this is where you can hear the murmur of tricuspid regurgitation. This is also where you can hear murmurs associated with ventricular septal defects. And then finally, the fifth intercostal space at the mid-clavicular line, this is the clavicle, so the mid-clavicle is here. So therefore, this area here, which is called the mitral listening area, is at the fifth intercostal space and the mid-clavicular line. This is also sometimes described as the apex of the heart because this is where the point of the heart sits. This is the mitral listening area, and this is where you can hear all the mitral murmurs, including mitral regurgitation, mitral stenosis, and the murmur of mitral valve prolapse. Before we talk about pathologic murmurs, let's talk about innocent or functional murmurs. These are murmurs caused by normal blood flow through the heart, and they're very common in children and also in young, thin patients. In patients who are thin and in children, you can get the stethoscope very close to the heart, and that means that you can sometimes hear blood flowing through the heart. These are usually soft murmurs, no more than a 1 or 2 out of 6, and these patients have no signs or symptoms of heart disease. And there are a number of these murmurs that have been described. You can read about them. One is called a Stills murmur. There's a pulmonic flow murmur. There's also a murmur called a venous hum. But all these are going to occur in young children or young thin patients, and they're going to be very quiet murmurs with no signs of heart disease. And let me go back to this slide. Normal flow murmurs are often heard in the aortic or the pulmonic listening areas. That's because in those areas, blood flows past the aortic and pulmonary valves. There's a slight narrowing of the area for blood flow, and therefore there's often some turbulence there. And that's where you often hear normal flow murmurs. The most important feature when evaluating a murmur is to determine whether it occurs during systole or diastole. So let's talk about the systolic murmurs first. These murmurs occur when the heart contracts or squeezes, and this means they will occur between S1 and S2. So in actual practice, when you're listening to murmurs, try to identify S1 and S2, and then you can try to identify whether the murmur occurs between S1 and S2 or whether it occurs after S2 and before the next S1. Remember that systole is shorter than diastole, so there will be a short space between S1 and S2, and then there will be a longer space between S2 and the next S1. Murmurs that can occur in systole are flow murmurs, which are benign, so systolic murmurs are often benign, but also other murmurs that are related to the contraction and squeezing of the left ventricle, so aortic stenosis, mitral regurgitation. Both of these murmurs require the heart to contract and squeeze and push blood over one of the valves. Pulmonic stenosis and tricuspid regurgitation are also systolic murmurs. And finally, the murmur of hypertrophic cardiomyopathy and murmurs associated with ventricular septal defects are systolic murmurs. In contrast, diastolic murmurs occur when the heart relaxes and fills, and as we just discussed, this is between S2 and the next S1. Many systolic murmurs are benign, but diastolic murmurs are always pathologic. There should never be a diastolic murmur present under normal conditions. And murmurs that occur in diastole are murmurs related to the relaxation and filling of the ventricles. So this could be aortic regurgitation and mitral stenosis. Both of these occur when the ventricle is relaxing and filling. Also pulmonic regurgitation and tricuspid stenosis. And then finally, before we get into specific pathologic murmurs, I just want to mention that the test of choice when evaluating a patient with a murmur is a transthoracic echocardiogram. This test allows you to visualize the valves. It also allows you to measure flow velocities, and this can usually determine the cause of any murmur. This is an echocardiogram on the screen from a patient of mine with severe mitral regurgitation. This is the left ventricle here, this is the left atrium, and this plume of blue color is evidence of blood flow backwards from the left ventricle into the left atrium, consistent with mitral regurgitation. This patient would have a holosystolic murmur heard best at the cardiac apex on physical exam. So now let's start talking about specific pathologic murmurs, and I'll begin by talking about the murmur of aortic stenosis. Aortic stenosis is very common, and you'll definitely see patients who have this condition on your clinical rotations. In aortic stenosis, the aortic valve gets thickened and fibrotic, like shown in this example on the screen here. And this causes a systolic crescendo-decrescendo murmur. And by that what I mean is that the murmur occurs in systole between S1 and S2, and the intensity of the murmur rises and then falls in systole. This is also sometimes called an ejection murmur, because this is the type of murmur you get when blood is being ejected from one of the cardiac chambers. And I'll play you an example of this murmur now. It is super high yield for your board exams to know the severe disease findings in aortic stenosis. So years ago, before echocardiography, there were certain features of the murmur and the physical exam that indicated a patient had severe aortic stenosis. The first one was a late peaking murmur. When aortic stenosis gets very severe, there's very slow flow across the stenotic valve, and that causes the peak of the murmur, when it goes up and down, the peak to be later in systole. Second severe disease finding is a soft or quiet S2. This occurs because the stiff valve can't slam shut, and that makes S2 a softer sound. And then the final finding is not related to the murmur. It has to do with the carotid pulse. It's called pulsus parvus et tardus. This refers to weak and small carotid pulses and a delayed carotid upstroke. Basically, patients with severe aortic stenosis, if you place your fingers on their carotid pulse, it is a very weak pulse with a very slow upstroke as the pulse goes against your fingers. Hypertrophic cardiomyopathy is a condition that I talk about in the video on cardiomyopathy, but I just want to mention here that patients with hypertrophic cardiomyopathy have the same murmur as aortic stenosis. The only way to differentiate hypertrophic cardiomyopathy from aortic stenosis using your stethoscope is by performing maneuvers. And I talk about these maneuvers in detail in the video on cardiomyopathy. I'll also talk about some of them later in this video, but I'll just mention here that the Valsalva maneuver is one of the most important maneuvers for distinguishing aortic stenosis from hypertrophic cardiomyopathy. To perform the Valsalva maneuver, you ask the patient to bear down as if they are having a bowel movement, or you can ask them to blow out with their mouth closed. This is called the Valsalva maneuver, and it leads to decreased venous return and preload. This will cause the murmur of hypertrophic cardiomyopathy to increase in intensity, but the murmur of aortic stenosis will decrease in intensity. That's because with less preload, there's less flow across the aortic valve, and therefore this murmur gets quieter. Moving on, let's talk about aortic regurgitation, also sometimes called aortic insufficiency or aortic incompetence. This causes a diastolic murmur, and the murmur is classically described as decrescendo and blowing. It's called decrescendo because over time it gets quieter as diastole proceeds. And I'll play you an example of this murmur now. Next murmur is mitral regurgitation. Mitral regurgitation causes a holosystolic murmur heard best at the apex. The murmur is also sometimes described as pansystolic. And what holosystolic or pansystolic means is that the intensity of the murmur does not change over the course of systole. And this is in contrast to aortic stenosis, which we talked about earlier. That's also a systolic murmur, but it's not holosystolic, it's crescendo-decrescendo. And the mitral regurgitation murmur is heard best at the apex, which is the mitral listening area that we talked about earlier. It's found at the fifth intercostal space in the mid-clavicular line. And I'll play you an example of the murmur of mitral regurgitation now. Next, let's talk about mitral stenosis. Blood flows across the mitral valve in diastole, so mitral stenosis causes a diastolic murmur. Classically, it is described as a diastolic rumbling murmur, and the murmur is always preceded by a sound in diastole called an opening snap. Let's take a look at this diagram at the bottom of the screen here. First of all, the mitral valve closes as a component of S1, so S1 is classically loud in mitral stenosis. You then have S2, and then the period of diastole begins. In diastole and mitral stenosis, what you will hear is an opening snap followed by a diastolic rumble, which is the murmur of mitral stenosis. And I'll play you an example of this now. A couple of high-yield points about mitral stenosis. You cannot get a left-sided S3 or S4 in mitral stenosis. I talk about the two pathologic heart sounds S3 and S4 in the video on heart sounds. Those sounds are caused by blood rapidly filling the left ventricle, and blood cannot rapidly fill the left ventricle if there is mitral stenosis obstructing the flow of blood from the left atrium to the left ventricle. You should also be aware that the time to the opening snap is associated with disease severity. Years ago, before the era of echocardiography, the physical exam would be used to estimate the severity of mitral stenosis, and in patients in whom there was severe mitral stenosis, there would be a very short time between S2 and the opening snap. Remember that S2 is followed by the opening snap in patients with mitral stenosis, and then the murmur occurs. So this time between S2 and OS would get very short in patients with severe disease. The reason for this is because in those patients who have severe disease, the left atrial pressure gets very high, and the high left atrial pressure causes the valve to open more quickly in diastole, and that shrinks the time to the opening snap. So this is a classic sort of old-fashioned sign of severe mitral stenosis that you should know for your boards. Tricuspid and pulmonic valve diseases are much less common than aortic and mitral valve diseases. I won't talk about them in detail in this video, but I will mention that the valve lesions sound just like their left-sided counterparts, however they're heard in different locations. So for example, at the right upper sternal border, you hear aortic stenosis. The murmur of pulmonic stenosis sounds just the same, but it's heard at the left upper sternal border. Years ago, people used to struggle in differentiating tricuspid regurgitation from mitral regurgitation using the stethoscope. And during that time, there was something called Carvalho sign that was used to identify tricuspid regurgitation. Carvalho sign refers to the fact that tricuspid regurgitation gets louder during inspiration, and mitral regurgitation, in contrast, gets softer during inspiration. The reason this is the case is because inspiration draws blood into the lungs, so there's more flow through the right side of the heart, and most right-sided murmurs get louder, including tricuspid regurgitation. Also during inspiration, there's less blood flow through the left side of the heart, so most left-sided murmurs get softer. Exhalation does the opposite. So this is kind of a general principle that you should know for your boards because it will help you differentiate murmurs. Right-sided murmurs increase with inspiration, and you can remember that because the second letter of right-sided is an I. The second letter of left-sided is an E, and that can remind you that left-sided murmurs increase with exhalation. Let's talk about a patent ductus arteriosus. This causes a continuous murmur, meaning it's present in systole and diastole, and the murmur is classically described as a machine-like murmur. I'll play you an example of that now. I'll finish by talking about maneuvers. Maneuvers are things you can ask the patient to do. They're performed at the bedside with the patient, and they can increase or decrease the murmur, and they're very helpful for making a diagnosis because certain murmurs will make certain valve lesions louder and other valve lesions quieter. Most of the maneuvers done at the bedside to evaluate heart murmurs modify the preload or the venous return to the left ventricle. There are two maneuvers that increase the preload and the venous return to the left ventricle. Those are the leg raise and squatting maneuvers. To perform the leg raise maneuver, you have the patient lie on the table and you raise their legs. Blood will fall back toward the heart, and that will increase the preload and venous return. For squatting, you simply ask the patient to squat, and blood in the legs will be forced back towards the heart, once again increasing preload and venous return. There are two other maneuvers that decrease preload and venous return. Those are the Valsalva maneuver and standing. We've already talked about the Valsalva maneuver. To do this, you ask the patient to bear down like they're having a bowel movement. This raises the intrathoracic pressure and compresses veins, and that drops the venous return to the left ventricle. If you ask the patient to stand, blood will fall towards their feet away from the heart. This is the opposite of the leg raise, and this also will decrease the preload and venous return. And if you understand this, then it's very easy to remember that almost all murmurs increase with more preload. There are only two exceptions. Those are hypertrophic cardiomyopathy and mitral valve prolapse. There are also a couple of maneuvers that can be used to modify the afterload on the left ventricle to change the intensity of murmurs. To increase the afterload, you can ask the patients to perform the hand grip maneuver. This is where you ask them to clench their fists vigorously. This will raise the afterload on the left ventricle. And then to decrease the afterload, there's a short-acting vasodilator called amyl nitrate that can be administered. This is really historical. No one does this in the modern era, but once again, years ago before echocardiography, amyl nitrate was used to cause vasodilation and lower the afterload, and then you would listen to the heart to see if there was a change in the intensity of the murmur. Changing the afterload has a number of different effects on the disorders that cause heart murmurs, and the way to remember all the effects of afterload changes is to think of the cardiac disorders that cause the murmurs as either backward or forward disorders. So backward disorders are disorders where the murmur is caused by blood flowing backwards compared to normal. For example, in aortic regurgitation, blood is flowing backward across the aortic valve. In mitral regurgitation, blood is flowing backward across the mitral valve. And in a ventricular septal defect, blood is flowing from the left ventricle to the right ventricle, which is backward. All of these backward disorders will become louder in terms of their murmur when there is more afterload. Afterload resists the flow of blood out of the heart, and therefore it makes it easier for blood to flow in the backward direction across a lesion. Forward disorders are disorders like mitral stenosis and aortic stenosis. In mitral stenosis, the murmur is caused by blood flowing from the left atrium to the left ventricle, which is forward, the normal direction. And in aortic stenosis, the murmur is caused by blood flowing from the left ventricle to the aorta, which is also forward and in the normal direction. For these disorders, the murmur will become softer with more afterload. That's because the afterload resists the forward flow of blood, and therefore the murmur gets quieter. And once again, mitral valve prolapse and hypertrophic cardiomyopathy are special disorders in a class of their own in terms of how they respond to afterload. Both of these murmurs get softer when there is more afterload. That's because more afterload tends to make the LV cavity size larger, and that decreases both of these murmurs. And that concludes our video on heart murmurs.